will be in your own language, and anything you read will also be in your own language. So having said that, Andrew, are you happy that we move forward?
I'm good to go.
Wonderful. Okay. So in that case, we're just going to set it live on Facebook. It's funny, I've done this so many times today, but when that wee circle goes round, there's still a wee heart skip in my...
Oh, I bet. I bet.
So,
Eurovision next year, Robert.
Yeah, absolutely. So, right, we're good. We are good. We are live and we are in the room, and we have Dr. Andrew Yeoman with us. So welcome. Thank you so much for joining us today on International PBC Day. It's so international that we've even included Wales. So, it's been a great day so far. So many webinars that we've had today that have had people in the USA, Mexico, and Argentina, all in the same webinar, is people from New Zealand and Australia and all the way in between. So it's been absolutely amazing to be part of this. And thank you so much for joining us.
Thank you very much. It's an absolute pleasure and a privilege to be involved. It really is.
So brilliant. So on that note, I'm going to invite you to so Andrew's going to talk to us about developing the patient-clinician partnership. Andrew, you have control of the slides, and I look forward to this. Thank you very much.
Okay, thank you, Robert. Once again, it's an absolute privilege and an honor to be involved in what's a phenomenal effort by everybody at the foundation, and to be part of a truly international event is fantastic. So to begin at the beginning, to quote Dylan Thomas, I'll keep it as Welsh as I possibly can. For those who don't know, this first slide is an image of Aneurin Bevan, who was the founder of the NHS in the United Kingdom, a personal hero of mine, and the health board that I work for is named after Aneurin Bevan, and he grew up about 15 miles from where I'm sat right now. So, and the reason I put up a slide of Aneurin Bevan is that he's a man who's very quotable, and one of his great quotes is, "The purpose of power is to give it away." And we always think of knowledge being about power, and improving care and improving the patient-clinician partnership in PBC is all about the transfer of knowledge, and therefore the transfer of power. And Aneurin Bevan said the purpose of power is to give it away. So just wait for the slide to load. So I think for a long time there's been a real power gradient in healthcare, and the traditional healthcare model gave all the power to clinicians. It gave all clinicians had all the knowledge. Patients and their families were often didn't have access to information very readily, or couldn't appraise it very readily. And so therefore the dynamic was very much shifted towards the clinicians. And patients were often reduced to a submissive, or at very best, a very passive role in their healthcare. They were told what needed to happen, and if they didn't like that, that was just too bad. And that's the very traditional sort of medical model. It was a very paternalistic approach. And perhaps unsurprisingly, this created a very adversarial dynamic where there would be frustration, resentment, and even anger, and often understandably so, as a result of a very paternalistic approach. Now, I think it's fair to say that a huge progress has been made in this area over the last few years, and it's great to see a lot of clinicians, doctors, specialist nurses, and allied health professionals really driving that change, as well as organizations like the PBC Foundation. But I think there's still a long way to go. So I think what I want to talk a little bit about today is how do we further that partnership working, and how do we get to a much more collaborative approach to healthcare. So if we think about partnerships, they shouldn't be seen as a zero-sum game. So a zero-sum game is where you have a total amount of something, and if one person has control over that, the other person loses out. So my interests, I win, your interests, you'll lose. So that's a very adversarial system that the traditional healthcare approach often set up. All the power, if you will, or the knowledge was held in one party, and so there was, when one person wins, the other loses. And we have to move much towards the non-zero-sum game approach, whereby we have to identify not so much this graph which shows an overlapping in the middle, but actually those two circles almost need to completely overlap. So it's not about interest, it's about shared interests, and about finding overlapping a situation whereby you can develop a win-win scenario. And this is probably best exemplified by another hero of mine, Bruce Springsteen, another very quotable human being. And Bruce often makes this statement that nobody wins unless everybody wins. And I think we need to think about that in the terms of healthcare delivery, and that this isn't about who gets what out of the relationship. It's about there's a shared goal, and that if we all get what's needed out of that, then everyone is a winner. And I think we can all sign up and agree to that. So I think when we think about partnerships, if you look at what a generic definition is that a partnership is an arrangement or an agreement between parties, sometimes two, sometimes three, who agree to cooperate to advance mutual interests. And I think sometimes that can be adversarial, and that's a very cold description of a partnership, and I don't think it relates very well to healthcare. I actually had a look at online for some medical dictionary definitions, and this was the first one that popped up on Google, and I was a little surprised at this. It says health partnerships are commonly understood to mean the interactive relationship between a doctor and patient, the former advising on optimal strategies for improving or maintaining health, and the latter following the advice and taking charge of his or her own health. And whilst there's elements of that I would agree with, I still think that definition, which is a very recent one, is still quite paternalistic. It's almost saying we as healthcare professionals will tell you what to do, and you will follow it, and only by following it will you take charge of your own health. And I think we need to move away from that sort of very narrow prescribed view of what a health partnership is. So we need to reimagine partnerships now moving into the 21st century. And this is what the UK General Medical Council, which is the regulatory body for doctors in the United Kingdom, stipulates in the duties of a doctor, which is the manifesto for what good clinical practice should look like. And it says that doctors should work in partnership with patients to further these common goals: to listen, to respond to concerns and preferences, to give patients the information they want or need in a way that can be understood, to respect patients' rights to reach decisions with us about treatment and care and ongoing plans, and to support patients in caring for themselves and improve and maintain their health. And this is far less controversial and much more collaborative, I think, but it doesn't quite perhaps go far enough as far as I'm concerned in terms of really getting to a better understanding of what matters to you. I think we still very much focus on a medical model of care and meeting medical endpoints rather than the things that really matter to you as people living with PBC. So I just want to focus just now on what are the challenges historically and sometimes now to partnership working, from both the healthcare professional standpoint on the left of the slide and from the patient or carer's perspective on the right. I think the commonest challenge from a healthcare professional's point of view is time. And I think it's important that you have an understanding of the relatively limited time we often have, both in a clinic or hospital-based setting, to be able to deliver all the things that we have to deliver. Now, that's not an excuse for poor practice or for poor communication. It's just perhaps to understand that there's a tension between you as the most important person in this, but then we have lots of other people who are similarly important to try and help support as well. So we need to find better ways of delivering that as doctors, but it's often helpful for people to understand that sometimes time can be extremely limited. The other challenge can be healthcare professional knowledge and experience. You may see somebody who's not particularly experienced in your condition, in this case PBC, and that can be a source of frustration, both from the clinician's point of view and obviously from yours as the patient or relative. I come back to the traditional paternalistic mindset of you do as I say, and I think that is slowly being phased out as the dinosaurs are retiring, but I think it's still somewhat evident in some clinical interactions, but thankfully becoming less common. And finally, some people are just not good communicators. Some people either find it difficult to communicate well, but it is a core essential skill of good medical practice to be able to communicate well, and that involves active listening as well as just being able to talk well at somebody. From the patient perspective, and again, I acknowledge this is coming from a clinician's perspective rather than from yours, and I'll come back to that a little bit later. But you may have had previous bad experience with a healthcare professional, and that might have set you, put the barriers up, and understandably so, about being open to further interactions. So in terms of partnership, it requires both parties to go into this as open as possibly to get the best possible outcomes and results. Some people still feel very intimidated by that power dynamic. You come to the big shiny hospital clinic and you're made to wait in a long waiting area, and sometimes people can be made to feel that they're a very small part of this process. But we have to try and make people feel as relaxed as they possibly can, so that they feel that for that appointment period, they're the most important person in the process, which of course you are. It's always astonishing to me sometimes how often people underplay their own symptoms. Some people do the opposite, but actually it's very, very frequent that people think the symptoms they're experiencing are not as bad, or that there's somebody else worse off, and they don't want to burden the doctor or the nurse with those symptoms because they must see people a lot worse off than you. And I always say to people, look, you might have a broken leg, somebody might have 2 broken arms and 2 broken legs and a broken neck, but you've still got a broken leg. So you still need help and you still need support. So whatever you think of your symptoms, it's important that you, if they matter to you, that you verbalize those in your interactions with your healthcare professional, so that we can get a greater understanding of what really matters to you, and we can try and find better ways of managing that for you or with you. Sometimes some people have an excess faith in medicine and science. That's not to say that medicine and science is useless, far from it, but I think there's a common perception that we have the answers to everything, and I think we have to be honest when we don't. And I'm a big fan of saying I don't know when I don't know. We shouldn't be using bluff and bluster and hiding behind this veneer of authority which says that we should have the answers to everything, because as you may have heard if you've listened to some of the other talks around genetics of PBC and the underlying causes of PBC, we don't often know as much as we would like to know in order to be able to work together with you to get the best outcomes for you. So the often perception is there must be a solution to the problem, but sometimes there isn't. And I think it's much better for partnership working that we're open and honest about that, so we can have a good and clear dialogue about how we can, if we can't fix a problem, how we can mitigate it, how we can make it easier for you to manage, and also for you to know that you're perhaps not alone in that situation. So I'll just come back to a little bit more the specifics of those barriers, particularly from the clinician's perspective. This is just to really highlight, in terms of what the time barriers are. And clinics are typically short appointments. They can be 20 to 30 minutes for new patient appointments, and sometimes as little as 10 to 15 minutes for follow-up appointments. And whilst we all wish we could have longer with patients in the clinic, and I'm sure you as patients wish you could have longer with us, we are somewhat limited in that. And we're always conscious as clinicians, and if we sometimes make you feel like we're rushing, we don't intend to do that. But obviously, we've often got people waiting in the waiting areas, and you might have waited and be late, running late in the clinic or on the ward yourself, and you get frustrated with that. But we get frustrated with that too. We would like to have more time, but time is always the most precious resource we have, and we would like to have more of it. And another thing, because PBC is a relatively uncommon condition, is that when you have your first contact with a hospital specialist in relation to it, you may have had very many years of not being ignored, but perhaps being passed over and say, well, it doesn't seem to be anything to worry about, or we don't know what's going on. And so when you do get to that appointment, you may have several years worth of stored up questions and frustrations to come out. And that's fine. We are there to try and deal with that and to try and give you the answers that you need. But it can create an extra time pressure. And I think we have to find open and creative ways of managing that. And I think the work of people like the PBC Foundation is absolutely critical in helping us fill in those gaps, and also perhaps use the sometimes limited time we have as best as we possibly can to get all your medical care as well as your information requirements. In terms of knowledge barriers to successful partnership working, well, because PBC is a rare disease, your doctor or nurse may not be that familiar with PBC. Within the UK and to some extent worldwide, there's a lack of hepatologists. The next bit refers to the Lancet Commission, where they did a survey of all acute hospitals in England, and less than half of the ones that responded had the adequate number of hepatologists to constitute a proper service. So that means that there's a significant proportion of people with PBC in the UK who are not seeing hepatologists, and that can be fine. There are gastroenterologists and general physicians out there who do have good knowledge of PBC. But it may be that your first contact in a specialist clinic or a hospital clinic is with somebody who hasn't got a vast experience of PBC, and they do know what the condition is, but they might not have an advanced high-level knowledge, and that can lead to frustration from your perspective as well. And as I've said, there's still lots we don't know in terms of what causes PBC and how best to manage it. We still have a limited number of medications to treat certain things. And in relation to fatigue, we don't have any medications to treat it. So there's still a lot of progress we need to make as clinicians. But I think being open and honest is a really important part of managing that. In terms of the paternalistic approaches, there's no doubt that will impair successful partnership working. I think that I know best strategy coming from doctors is becoming, thankfully, a lot more rare, but it's not by no means stamped out. But it definitely will prevent a collaborative approach to healthcare. And I think the other thing we have to start to move towards is perhaps moving away from the fixation on medical endpoints. So when we look at how effective a new treatment is for PBC or any other condition, we look at laboratory values. We look at, does it change the amount of fibrosis or scar tissue in your liver? Does it make your ALP look a little bit better? But actually, for some people, that won't make a blind bit of difference to their overall survival or quality of your life. So we need to get a much better understanding of what matters to you, because depending on the stage of the disease you have, depending on your age and other health conditions, it may or may not have any significant impact for you at all. And so we need to get a better understanding. So paternalism is very much against the principle of personalized medicine. So personalized medicine isn't just about understanding genetics and how that affects you in terms of the conditions and how those conditions will behave for you, but it's about how we personalize the approach for you and make sure we're not over-treating people who will do well from a condition like PBC, and we might then cause lots of side effects without a long-term major benefit. So I think that paternalistic approach needs to be flipped to a much more collaborative approach where we understand what matters to you. Communication barriers, well, I think time constraints usually represent the biggest impairment to collaborative working and partnership working, particularly around goal setting. And I think goal setting is quite a new thing in terms of healthcare professionals thinking about that, but it's really sort of setting out some objectives quite early on in consultations about what we're trying to achieve and how we can work together to achieve those. Clear communication about that can really help focus everybody's minds. So sometimes we say, particularly if we've got a very limited time, sometimes being honest from the outset and say, look, we've only got a relatively short period of time today, but you will have follow-up appointments to delve into some of these things. So let's focus on what matters to you most and what things that affect you most, so we can really utilize that time really effectively. In terms of communication, I think the signposting element, I think it's something that doctors are not particularly good at doing, and I think are getting better, but I wouldn't say that's universal. So, you know, I signpost all my patients to the work of the PBC Foundation. They don't pay me to say that. But I think it's really important that doctors and healthcare professionals signpost patients to trusted information resources so that you can build your knowledge and you can join communities of like-minded people or people living with PBC. And that can also help future consultations because then you're pre-armed with more knowledge. And I think that's always a good thing. The final thing I want to say on communication barriers is that conflict helps no one in this situation. And I think it's not about us saying to you that people have to behave in a certain way, but I think because it can be very frustrating living with a rare disease, and you may have not had the information you've wanted in the past, sometimes that can lead to quite a lot of frustration. And I think wherever possible, if you can, try to give that new clinician a clean slate, so to speak. It's important, if you have those frustrations, to sort of outline those at the start and say, I'm a bit frustrated because I've not had information on this, that, and the other. And then that can be helpful for us as doctors to say, okay, well, we've got something to build on there. We can start to work on your or the needs you have in terms of your blood tests, whether you've got significant scar tissue or not, and what the next steps will be in terms of treatment. So it can be helpful for us to know if you've had a frustrating experience before, but where possible, you know, if we have a clean slate when we've met you for the first time, as frustrating as it can be sometimes when you've gone around the houses, that can help us get to the information you need much, much quicker. So this isn't not just my experience. The PBC Foundation has done a lot of great work now on asking you what your experience is of healthcare in relation to your PBC. And this, unfortunately, thanks to COVID, This would have been presented at the British Society of Gastroenterology this year as an oral presentation, and Robert would have been delivering that presentation. Sadly, that's been postponed into next year. But that's a really good example, actually, of how things are changing in medicine. Because if you'd asked me 10 years ago, would somebody who works in a patient support role be giving an oral presentation in a medical conference, I wouldn't have thought that it would have happened. And so the world is changing dramatically, and I think for the better. But the PBC Foundation app is extremely useful source of information, so we can build on these conversations and develop partnerships further. And this was based on 3 major questions that you were asked to fill out in the survey, and they were filled out by nearly 190 people. The first question was, did the clinician, doctor or nurse, tell you about your liver blood test results? And that only happened in 75% of occasions. Now, had you asked a decade ago, it would have been probably less than that. But still, that means a quarter of people don't really know what their blood tests are telling them. And I'm assuming that because these are people responding on the app, these are people who would want to know. Some people are not that bothered in knowing if the doctor's happy. But actually, if you're involved with the app, chances are you're going to be much more engaged with your healthcare, and you really do want to know this information. So 1 in 4 people not getting the information they want on their blood tests. Actually, an even lower proportion then actually had explained what the blood results mean. So just regurgitating a set of blood tests, we can all do that, but it doesn't help your understanding, and it doesn't help build a partnership built on sort of mutual respect and trust if we don't explain to you what that actually means. So you need to understand, A, what your blood tests are, but what does that mean in terms of your condition now, how that will change in the future, and what medication or otherwise you should be taking for that, and what follow-up plan needs to be instituted. So I think the first 2 questions are really important things to understand. The final question was, do you know the implications? And as I said, that relates to the follow-up plan and the change in management. And that only happened in around about 2/3 of patients were actually told what the implications of their blood tests are. So I think that shortfall, I suspect it is better than it has been before, but it's still nowhere near where it needs to be. It should be more or less universal, that if you want this information, you have this information, so that we can work in partnership. So bridging the gap. So, I mean, the work that the PBC Foundation has done and presented on the previous slide is a PREM, which is a patient-reported experience measure of their healthcare. We're starting in the NHS to have a better understanding of the need to record both the PREMs and the PROMs, which are patient-reported outcome measures. So that's in terms of perhaps response to different medication, in terms of symptom relief, etc. And I think we do need to be far better at collating this information, either via surveys, through working with people like the PBC Foundation, to utilize this information to change clinical practice, to form a positive feedback loop whereby we get information from you in clinical consultations where you tell us what matters most to you. We gather information on an aggregate basis from the foundation through the app that tells us a broader picture of what's happening across the whole of the UK and beyond, so that we can refine the approach to management in the clinic and give you better quality information. And it's absolutely fair to say that the foundation has done more than anyone to lead on this work in PBC. So this all comes down to care navigation very often, and I think it's one of the great challenges in healthcare, because every different service, whether it's a cardiology service or a liver service or an orthopedic surgical service, has different, the patients will have different needs, and the service is set up somewhat differently. So it's quite hard for the NHS to give a single care navigation pathway as such. But actually, if you can navigate your care well, you will have a much better experience, and you will be able to build a better relationship with your healthcare professionals and vice versa. But in terms of how, from a clinician's perspective, how can you get the most out of your outpatient appointment or interaction with a healthcare professional? And the first thing I always say is be as prepared as you possibly can be. And that means knowing about your medical history, including current medication and doses, and preferably when you started taking those medications. It's very frequent and a common finding in clinic where people don't bring their medication with them, and we don't know what drugs they're taking and what doses, how long they've been on them for. And that can lead to a fair bit of time taken up trying to gather that information, and then still meeting a bit of a dead end. So wherever possible, if you have all that, if you can write it down and on a bit of paper, even better, because then we can come back to that later, and we can spend more of the precious time we have with you getting to what matters to you most. A similar knowledge of symptoms and timing of symptoms and what exacerbates or relieves them is similarly useful, so that can then be crystallized, and we can then spend all the time we have then developing an assessment and management strategy for you. And that's all about understanding what troubles you the most, what matters to you most, what do you want out of the consultation most on this particular occasion. It's useful for you to know your local hospital as well, so you have an understanding of whether you're visiting a very small hospital, where it may not be a hepatology department, but a gastroenterology department. Who is your caregiver? Who's your consultant or nurse? And crucially, how to contact them. So my service gets a lot of contacts from patients, and they're all justified contacts. So people are usually wanting more information, or perhaps we've forgotten to write to them with their up-to-date blood tests, or they wanted specific information for health insurance, for example. Don't be afraid to contact us. We expect to be contacted about things, and we would much rather know if there's a bit of information you've not had to date that you would like to have, so that we can continue to have that foster that good relationship with you, so that there's no conflict in the relationship. Because if there's no conflict in the relationship, then we'll have a much more open and transparent partnership that will lead to better outcomes for you. So don't be afraid to contact us when you need us, but know how to do that. So in terms of key PBC specific questions to ask, this is quite generic, and some of these things undoubtedly will be covered in other talks through this this marathon that Roberts and Colette have organized today. But the basic ones are, what are my blood tests, specifically the alkaline phosphatase enzyme level? Because that's of significant importance in terms of treatment options in PBC. If you're on ursodeoxycholic acid, what dose are you taking? But you need to ask, have I responded to that medication? Not just have I had a partial response, have I had a complete response? And if I haven't, do I need additional medications like a obeticholic acid, or OCA for short? If that's not an option, or if you fail that treatment, are there other therapies available? Are clinical trials available to try to prevent the progression of your disease? It's often useful to ask, or if you don't already know, do you have major liver scarring? Because in days gone by, that was always done by a biopsy. We can now make a good determination of liver fibrosis in the majority of people without a biopsy, via either a FibroScan or a blood test called ELF. And so we can find out other ways. And this also has importance for the prognosis and the future behavior of your PBC. So it's an important question to know and understand. If you have cirrhosis, some people will progress very, very slowly from there and may not develop problems, but what things do you need to look out for? What are the complications of cirrhosis that need to be considered? And crucially, who do you contact? How do you contact your healthcare professional if those problems arise? It might be via your GP in the first place, but they might have a nurse advice line like we do in Gwent. Or they might be, you can contact the secretary for further advice, because very often if you go straight to the GP, they'll often say, well, you're under the hospital team, this is a rare disease, I don't feel very comfortable with this, you're probably better off going into the specialist clinic and contacting them. So understanding how you contact if a problem should arise is really important. How do I manage my itch if that gets worse? Well, we use there's a whole treatment ladder of different things we can use to treat itch in PBC. So if you've had one treatment, how do you get in contact with us if that's not working, and what are the next steps? And the final question, obviously, generically in relation to PBC, is how to manage my fatigue. And that remains the hardest one. And I know Colette is talking a little bit as movement as medicine, but I think very often using resources like the foundation and speaking to other people, getting tips from them about how they've managed this is as valuable as anything. So I come back to my firm belief that I think knowledge is power, and I don't mean power as in a bad sense. I mean power for good. And I think the more knowledge we share, the better we can understand PBC, both generally from a biological perspective, but crucially its effect on you and how we can help you manage that. So we should have in-depth medical knowledge of the condition, and you have in-depth knowledge very often of the condition, but particularly so you're experts in your disease and how it affects you and how it affects your life and that of your family as well. And sometimes you will know more than some doctors, as it's a rare disease. So sometimes it's okay. If you're going to see a GP, they might not know much about it. Some GPs may only see one person with PBC in a decade or so. So it's very difficult to expect them to know a lot about that, and just to acknowledge that and be aware that there's a reason why they don't know a lot about it. But sharing your experience is powerful and educational to us as doctors, and I think we are much more disposed now to using that information wisely. In the same way we look at clinical trials, We can use information that we gather on your experience of this and where the shortfalls are about how we provide better care for you, and that we do that in partnership. And to remember that the purpose of power is to give it away. So share that information is really, really important. So let's move beyond. Perhaps I've been talking about a bipartite partnership between the clinician and the patient. And I think crucially here, I think the PBC Foundation is acting as a very, very honest and effective broker in these partnerships, acting as a very efficient conduit for information between clinicians and doctors. And we work very closely, a number of us work closely with the foundation on developing this knowledge transfer, if you like. So we form tripartite relationships and partnerships so we get to a better shared understanding of the condition and how we can help you manage it. So in summary, I think I'm sure we'd all agree that developing partnerships is essential for high quality PBC care. And I think the burden of the symptoms in relation to PBC, your emotional and physical well-being, and your medication compliance and your long-term clinical outcomes can all be affected by the success of a partnership. If you have a poor relationship with your healthcare professional because they're not very supportive or they don't listen well to you, then you're less likely to take the medication as prescribed because you don't understand the reasons for prescription or why you're taking them. And that can lead to adverse consequences, and nobody wants that to be the case. So I think it's about development of mutual trust and respect, and that's integral to partnership working. And ultimately, that's much more rewarding for all parties and better for you because you'll get better health outcomes. And just reiterate really the PBC Foundation's role in fostering these partnerships and acting as almost as an honest broker in all this, and providing you with as patients with perhaps confidence that this is not the healthcare system telling you this. The PBC Foundation is sort of independent of what we do as the NHS or as healthcare professionals, and so that's another trusted source of information for you. So I started with an Anne Brevin quote, and I'll finish with one. This is my truth, tell me yours. I've spoken a lot about my perspective on this, so I'll be very interested to hear now on your perspective on how we can further develop partnerships. Robert, are you there?
Yeah. Are you there? Can you hear me?
I can hear you.
Wonderful. Thank you so much for that. For a number of reasons. One, you always have a good presentation because it answers the questions before the question session starts. So there was a number of questions that came up. So for example, Julie talked about surely the whole relationship is based on trust. Yeah. Just at the moment that you were talking about how important it is to build trust. So you've actually taken out a number of questions already, which tells us that actually you've hit the nail on the head. So thank you. And also thank you for your kind words about the foundation and the work that we are trying to do. And to be fair, you know, you kind of sang the praises of the foundation, but that BSG paper was something that we worked together with VNOD as well. And so it's again highlighting the importance of the partnerships and bringing those different expertise into the conversation. So yes, we had a role as an organization, you had a role as an experienced clinician and used to these kind of events, and then the patients had a role by bringing us their experience so we could then fight their corner. And I think that absolutely exemplifies you know, what we were talking about in your presentation. So thank you for that. So I do have a couple of questions for you. Now, we're just going to take a side step, if I may.
Of course.
We had a question with regard to PBC and COVID. So if you're happy to field that, then great. Cool. But before I ask you, just to let Carmen know that right at the start of the day, well, actually, it was round about 9 o'clock, Dr. Marco Carboni presented a whole hour with questions and answers on PBC and COVID. So if that's of interest to you, it's absolutely worth going back and having a look at that video because it gives you a whole lot of stats and facts and all that kind of thing, which will support Andrew in his answer. So the question is, Andrew, PBC, is it considered a risk group with regards to COVID-19?
That's an excellent question, and there's not a straightforward answer. So it does depend on the severity of your PBC, and what we understand in terms of risk factors for COVID or having more severe COVID is if you have a single major organ failure. So if you've got renal failure or liver failure, then you're at significantly increased risk of adverse consequences of COVID. But if you don't have advanced liver disease, if you don't have cirrhosis, then your risk is probably not dramatically different to the rest of the population. Obviously, diabetes can be a risk factor, which some people can have independent of PBC. So PBC per se is not a significant increased risk factor, but if you have advanced liver disease from PBC, then you are probably you will be at increased risk, and you would fit into a shielding category based on that if you have cirrhosis or any evidence of liver failure.
Wonderful. Okay, thank you. And just while we're on the side questions, if I may, we've got a question in the room that what does a score of 10 mean on a FibroScan? Now, I know that's a huge, wide question, but if you just kind of, thank you.
Yeah, no, it's important. So I raised it's important for you to understand and ask the question. So it's good that people ask the question. So I think a FibroScan is a measure of your liver stiffness. So we use that as what we call a surrogate. It doesn't directly tell you 100% that stiffness is due to scar tissue, but in many contexts, it does mean scar tissue. In PBC, scar tissue to the point of cirrhosis would be 15 plus, and often 17 plus. So 10 means you've probably got what we call mid-range fibrosis, mid-range scar tissue. We know the liver tends to be stiffer in cholestatic disorders like PBC. What that means is that PBC is a condition where the bile doesn't come out of your liver very well. So even just having a liver that's got a little bit of bile backlog, for want of a better phrase, can be a little bit stiffer. So 10 isn't a worrying reading, and it can fluctuate. So sometimes if you've had a FibroScan after a heavy meal, sometimes that can be slightly higher, and the next time around it might even be slightly lower. So 10 wouldn't worry me as a score, but it would warrant following that up. Usually I would normally do that in about 18 months, 2 years after the previous one, just to make sure that that's not changing.
Perfect. Okay, thank you very much for that. The patients that are here today have been so engaged and so knowledgeable. It's been really great to get their questions. And it's been fabulous today where you ask a question, you see a clinician go, right. So it's really, really good that that's happening. So again, here's a personalized question, but we want to open up to generally. So this kind of encapsulates all the questions that we have. So let's break it down piece by piece if we can. So the comment is that my GP does not get the blood tests, etc. Shouldn't the information be shared? So how do we get the information from the specialist first to the patient, and hopefully obviously to the GP as well? So if that's not happening, how do we empower the patient to make that happen, please?
Yeah. So this is a really crucial point for the whole of healthcare across the world. So I think the best way to do it is to cut the middleman out, namely the GP. So the thing is, the GP will get huge numbers of results, and they'll only need to action the ones that are abnormal. So if you think of all the patients that a GP will see or look after, if they go to a hospital clinic, every single time they should get results from the hospitalist, but sometimes if they're normal, they might not get a copy of them. So we should be letting people know direct. Now, I accept that doesn't happen universally. In large parts of England, some organizations like Birmingham, for example, people can actually log in and look at their own blood results. So I think even though people often get letters to their home address from their consultation, those don't always routinely put the blood results in. And I think the reason why there's been a reticence to do that is obviously whether people would then understand that or not. But actually, I think we should give people respect that they've got the intelligence to be able to look at that themselves. And it's a good way of actually people getting more knowledge about their disease, asking the questions. So as long as we stipulate that, your blood tests are normal, you might still want to ask what the ALP is. What does ALP mean? It's a good conversation starter. So I think we're not there yet with that, and there's all kinds of arguments about governance and should we be sending information out in letters in the post that can be, intercepted, etc., etc. None of those really washed. We should be sending information out to all people if we're not communicating during the clinic consultation what the blood tests are and what the next steps are. And so I think we have to be guided as well what people want. Some people don't necessarily want that, but for those who do, then definitely they should have access to that information on their clinic letters. But if you do want further information that you're not getting, then it is wrong for any team to decline you that information. It is your right to have that information, and you should have that explained to you if you've asked for it, if you've not had it before.
Yeah, brilliant. Thank you. So I know that a lot of what you said is UK based in terms of the experience and the data. And we also, if we're honest, we've seen improvements in the UK, but we're not quite the finished article in terms of this kind of best practice.
Oh, nowhere near.
But then we're further down the road than many other countries. And there are cultural aspects to, you know, doctor knows best and all of those kind of things that we need to address. So, for example, you know, we've got somebody in the US. Now, they were diagnosed, which is great, and that's fabulous, but they were given no resource information, no signposting to a patient information service, and those kind of things. So, obviously, as a patient advocate, I have a view in the sense that actually the best thing to do now is to take the information that you've found from the foundation, so the guidance documents and those kind of things, and then take that to your doctor and say, like, just to let you know, I found this immensely helpful. Why don't you have a look at their information? And if you rate it, maybe you'll signpost other patients to it. As a doctor, what's your thoughts on that kind of approach?
I think it's absolutely the right way to go about it, because I think, you know, different healthcare systems will have different degrees of expertise looking after people with PBC. And so one of the really important things I want to say is that the information on the PBC Foundation site is all fact-checked. It's all validated. It's all verified by clinicians in the field. So you can be certain that all the information on there is clinically accurate. Now, some of the things about care navigation, some people could argue that's my personal perspective on it. But I don't think anybody would disagree that actually patients being better informed about their condition can only be a good thing. If you're not getting the information you need from your doctor, you'll need to get it from somewhere else. And the PBC Foundation is the most trusted source to be able to get that. So I think that won't always get a positive response from a healthcare professional. Some people are very, very resistant and don't like being told what to do. But nonetheless, you have to be satisfied that you're getting the information that you need. The PBC Foundation will give you trusted information, and then if the health professional doesn't take that on board, I'd suggest you get yourself a different healthcare professional.
Okay, strong words, but thank you. All right, ideal. So a bit of a loaded question, but what are your thoughts in terms of the lay guidelines and the role that they play in empowering patients to ask the questions, and again, trying to build that relationship with your clinician?
I think guidelines are both a blessing and a curse. Okay, so guidelines are written by experts for people who are not experts in the condition, and so we've always had a problem with translating guidelines into an effective document that people who don't know much about a condition can find and use very quickly. Lay guidelines are absolutely the way to go because they empower patients to be able to ask the right questions of their healthcare professional. I think every guideline should be able to be crystallizable to a single page of A4 or a single algorithm, because otherwise, how are you going to get people who are not expert in that area to be able to navigate that?
Yeah.
There are so many guidelines out there now. I mean, when COVID hit, there's something about 80 to 100 COVID guidelines for different things. So it's impossible to keep up with all those things. So things have to be as simple as possible. So I think lay guidelines are really, really important because they really do a number of things. They focus on what really matters by being that concise, and they empower people to be able to ask the questions that they need to ask, such as, what's my alk-phos doing? What's my stage of liver disease? Am I on URSO? Am I on the right dose? Am I responding? Yes, no. Do I need other therapies if not? So you can encapsulate all that into both a clinical guideline for primary care and non-hepatologists, and you can also translate that easily into lay guidance, just making sure the difference between the two is just tweaking the language, so using lay language rather than medical speak.
Yeah, brilliant. All right.
So I think they have a critical role.
Okay, brilliant. Thank you very much. And again, without firing a loaded question at you, but one of the things that we often experience, particularly in the helpline, is, and you know, with COVID being as it was, and there's pressure on units, pressure on doctors. But when things go missing, shall we say, so maybe there's not a follow-up when you were expecting or promised, we often hear the words, "I don't want to bother my doctor."
Yeah.
So again, any thought as a clinician, any thoughts on that in terms of what can you say to patients that are thinking along those lines? And if it does happen, that naturally stuff can get missed.
Yeah.
Particularly with a big system. So any thoughts on that?
Yeah, no, I mean, lots of thoughts and lots of things, Robert, as you know. I would say that you have a right to information about your health. And if you haven't received the information you need, then you should ask for it. Now, if a doctor doesn't respond to a polite request for further information appropriately, the issue is on them, not on you. So you should ask for information. Personally, I would always rather know of new developments rather than, because we know that our clinic waits can be longer than desirable, and COVID obviously has an impact on that. And I think as we move towards more personalized medicine, as we move towards telemedicine or video consultations, having a better understanding of how we share information about changes in your clinical condition or symptoms is a good way of us getting to better systems of providing care. So we can't always do it face-to-face in COVID world. So we need to find better ways of communicating with one another. So if you've got a new symptom, even if you're not certain it's related to your PBC, get in touch, because sometimes we can just allay your fears. You might be very worried that a new symptom means something very worrying, but we can often reassure you very simply. Whereas sometimes you might be sitting on a symptom which might be quite mild, but you might get really worried about for a couple of months before your next outpatient appointment. So it's better to ask. And I think a reasonable, polite request, not met with a reasonable response, is the doctor's problem, not yours. So you have a right to the information, and we would much prefer you ask, or you should inquire, so you can get the information you need, not sitting and worry about it for months on end.
Fantastic. That's really helpful. Thank you. So there you go. So Julie, exactly what we're talking about. She's been diagnosed 18 months and only now just found the foundation. And that's really helped. So that's really, really great to hear and really reassuring. So thank you. If we can take another sidestep from the topic as advertised, and been asked about how often should FibroScan be planned into care pathways?
Good question. So we don't have really good studies to know how often it should be done, but I think it depends on a number of different factors. It depends on how long you've had PBC for. It depends on what your previous reading was. In general, PBC is a very slowly progressive condition. So if you've got a normal FibroScan and you were diagnosed with PBC, say 10 years ago, that's really very, very reassuring indeed in terms of the progression of scar tissue. And you might be able to leave that for 5 years before doing it again. If you're newly diagnosed, you probably want it done within a couple of years. But again, if your blood tests respond really, really well to urso or to another therapy, then you don't need it as often as if you haven't responded. We know younger patients tend to have more rapid disease progressions. If you're diagnosed with PBC at a very young age, particularly under the age of 40, then we would probably do it a little bit more frequently. So coming back to that example of 10 that I was asked about, I would typically do that, depending on the context, I might do that in 1 to 2 years after the original FibroScan. The beauty is that it's non-invasive. You can do it as often as you want. It's not particularly expensive test. So I think we do have the option of doing that much more frequently than we did with biopsy. So I think it does have to be couched by how long you've had the condition for, what your baseline FibroScan is, age, etc. But I certainly think I would do it every 5 years in people who've got very, very mild disease or had it for a long time. But every 2 years in people who've perhaps got an elevated reading to begin with or are not responding to URSO or OCA. But again, if you've got a high reading to begin with, I might be doing it every year. And some people have done it every 6 months. So I think we've almost got this sort of sliding scale of frequency. But again, it's about communication with you about what stage your disease is at now, what your PBC risk score is, etc., etc. And I think all those things come into the play. So I can't give you a single answer. But again, it's about if you ask the questions about how bad your liver tests are, how bad your fibrosis is, how well you've responded to treatment, you can refine how often you do your FibroScan based on that.
Wonderful. Thank you. I've got one last question for you, but just before that, again, somebody who's preparing for their appointment this week
Yeah.
is actually just really had a great boost in terms of helping them make their list and prepare for that. And I think that absolutely hits the spot. So thank you so much for everything you've brought today. So again, as we're on the side topic, and just before we close, can allergies be a part of PBC? Again, that's quite a good question.
Yeah, it's an open question. I mean, anybody can have an allergy. I mean, I think the broader question is that we know PBC is an immune disorder, okay? And some immune disorders can be triggered by medications. That's not necessarily to say there's an allergy as such, but the immune system can react to medications, and in some cases that potentially could trigger PBC in the same way it can autoimmune hepatitis. So we don't think of allergies as being particularly more common in people with PBC compared to the general population.
Okay, brilliant. Thank you very much. Okay, here's a question. I haven't been given an appointment. How do I get my prescription renewed when my medication is nearly run out? Thank you.
Yeah, good question. So it depends on where you live. I mean, some GPs will be happy to prescribe Urso in particular. In some areas, OCA is a hospital-only prescription. So the first protocol should normally be the GP surgery. But if you've already got a close relationship with your hospital clinic, if you see a specialist nurse in particular, you can contact them directly and they can usually issue a repeat prescription for you. But if you're not aware of a specific helpline, or you've not had good access to the hospital clinic before, then the GP can be the first point of contact for you.
Wonderful.
But
okay.
I would always say as well, ask usually at least a fortnight before your medication runs out, because it can take a bit of time to get them out to you.
Perfect. Thank you. Just a question firing. So let's see. I've not even got a question to proofread it. So, diagnosed PBC with AMA. Liver biopsy and FibroScan is good. Oh, do you have PBC or not? Oh, there's a tough question. They told me I was in the early stages 4 years ago. And then the new doctor doesn't think they've got it. So the patient's kind of confused. So where can we start to try and get an answer and a clear PBC diagnosis, please? Thank you.
So you look at the natural history stuff, the studies is that if you have an AMA that's positive, if you follow people up for long enough, most people will develop PBC. The big question is, who has PBC right now? We are generally more than happy to give you a diagnosis of PBC. If you have an AMA positive and a raised alkaline phosphatase, you have PBC without a biopsy or not. So if your alkaline phosphatase is elevated, you have PBC. Some people do have very mild disease, and the biopsy can be normal or near normal. That means you've got early stage disease. As we know, that doesn't translate to whether you get itch, and it doesn't translate into how bad your fatigue might be, because those things are independent of the stage of scar tissue in your PBC. If your alkaline phosphatase is elevated with PBC, you should be offered therapy with ursodeoxycholic acid. As I can see on the text there, that naltrexone we use as a treatment for itch. It has no impact on the underlying disease in PBC. It doesn't have any impact on the immune disorder of PBC, but it can be effective in some people who have significant itching. So if your alkaline phosphatase is elevated, and an AMA is positive, you've got PBC, and you should be treated.
Wonderful. All right. Thank you very much. And that's bang on time. So thank you. So I'm just checking. There's no other questions on Facebook. So we're here in the room. There's no other questions there. So again, ladies and gentlemen, those of you that joined us for this session, thank you so much for your time and energy. Some great questions in there for Andrew. Dr. Yeoman, thank you so much again for your time, your expertise, your knowledge. The questions are coming in now, but we're going to have to try and move them on to the next session with apologies. So those of you that are with us, we start our next session again on the hour, 5 o'clock UT time, where we're going to discuss PBC and pregnancy. And other than that, all that's left for me to say to Andrew is thank you so much, and I hope to see you again soon. Thank you, sir.
Congratulations.
All right, thank you. Okay. Right, and we'll just close this room now. So thank you very much.